We're live now.
Hi everyone, welcome back to another session with Periodontal Universe virtual chatting session. My name is Tiffany and I'll be helping to facilitate this session today. We have an exciting presentation with Dr. Tolmie, and on that note, feel free to take it whenever you're ready, Dr. Tolmie.
Sure. Good morning, everyone. So again, my name is Dr. Chris Tolmie, and with today's talk, I just wanted to give you all a little bit of an insight as to how I got into dentistry, kind of the path I took, and some things that you should be considering as you're transitioning from undergraduate into going into potentially dental school or any other type of professional school that you may be considering as your long-term career. So if people have questions, will you all let me know if they type something? Yeah, okay. And my voice is still recovering, so if you can't hear me at some point, just let me know, kind of like wave at me. All right, so.
Oh yeah, we'll save all the questions towards the end.
Okay.
If that's fine with you.
Yep, that's fine. So the main things that we're going to be covering in today's presentation is my personal experience, how I went from undergraduate to where I am today. Life after dental school, which would be my current setting, my current work environment, the different things that I'm doing day to day, the different types of jobs that I had after dental school before I got to where I am currently. Then I have a whole bunch of cases to go through, a lot of pictures to show you all of things that I'm doing in the office. Also a big focus on periodontal health and the connection between the mouth and the rest of your body. So the systemic connection between your dental health and full body health. Then I have one bigger case to go through that has a lot of multidisciplinary aspects of it, including other areas of medicine and how they integrate with dental medicine. And then we'll finish it up with the current technologies that I'm using in my offices. So my personal experience, pictures here on the far left, that's when I graduated. I went to University of Maryland Dental School. So that was on graduation back in 2016. This was my family, so my mom, my dad, and then I have two younger brothers. The one in the pink shirt, he works for Under Armour in their philanthropy department. And then the one on the far right, his name is Grayson. He's a physician's assistant in emergency medicine down in Roanoke, Virginia. So it's interesting because he works in the emergency department. On weekends, they end up getting a lot of dental emergencies that come into their hospital. And as most of you probably know, there aren't dentists that work in the hospital. So the PAs, the emergency medicine doctors, are faced with trying to manage any type of dental pain without being able to give definitive care. So most of the time, they're just giving them antibiotics, some type of pain management medication, and maybe giving them some type of nerve block just to get them out of pain for 2 hours, which is like enough time for them to leave the hospital and hopefully not come back in pain before they can get to a dental office. So I've taught him how to do a lot of dental blocks, and he's taught some of his colleagues how to do those, because in medical school, they don't teach you anything about the mouth, really. It's maybe one day in the total curriculum because they rely on dentists for that. There's becoming a lot more of an integration between dentistry and medicine, especially with coronavirus. We'll touch on that later in the talk too, but every year now, it's becoming more and more integrated, even with just the way that insurance is reimbursing it. The middle picture is a mission trip that I organized to Tanzania, Africa. I did that my junior year and senior year of dental school at University of Maryland. So we went over to Tanzania and treated physically handicapped students, specifically at a school that my family built back in 1999. So they're all primary school age children who don't have access to medical care, including dental care. So the purpose of the school is to provide them with their education along with any healthcare needs that are diagnosed to them by their caring physicians. So both years I went over there with a group of probably like 5 to 8 other dental students, along with 2 to 4 other dental faculty. And we performed dental procedures on the students that needed them. We did periodontal exams, oral health screenings, oral cancer screenings, cleanings on all of the students. One of the interesting things that we realized over there was because The school is located at the base of Mount Kilimanjaro, which is a freestanding volcanic mountain, still considered active. And volcanic mountains have a lot of fluoride that they release. So the teeth of the students were very, very hard. They're very strong. They had minimal cavities, pretty much none, but they had a ton of periodontal disease, a lot of gum infection. So most of the treatments done over there were periodontal surgeries, periodontal infection-related abscesses, but not much decay, not many cavities, not many fillings. The far right picture, that was the group that went with me my senior year. And we actually all lived together my second, third, and fourth year of dental school in a row house in downtown Baltimore near Camden Yards. So they're all practicing now in New Jersey. And here are some pictures more of my current life. The upper left are some of the other dentists that I work with. The top row middle picture, that's most of my dental team that works in one of my offices. My mentor is the one that's standing in the back with the black shirt on and black hat. And then there's some of my business support team, dental assistants, hygienists, other doctors. So outside of work, we still interact with each other. A lot of your success once you graduate from dental school is based off of the relationships that you build with people and building loyalty and trust amongst all of your colleagues. Not necessarily how good you are, but it's more about how much people can trust you. Because I'd much rather go to the doctor who says, I don't know, but I have access to the specialist who can help you versus someone who's saying, oh, I know how to do that. I know how to do that. And they're really just like not really telling you the truth all the time. So it's better to have a strong team than to feel like you can do it all. The top right picture where we're all in black, that's my office-based team in Midtown, Miami. And on the lower left, that was the day that I placed my first set of implants on my office manager. So I needed a patient and she needed 3 implants. So she volunteered. And then the male to the right, he's the one who hired me 3 years ago to work for Pacific Dental. And he's been a really strong influence in my life since then in terms of coaching me, mentoring me, both in my professional setting and outside of the workspace. The bottom row middle picture on the right, Dr. Sweeney, she's my associate that I hired about 1.5 years ago. She works with me full time and I'm coaching her, I'm mentoring her. And on the left side, that's my main hygienist. I have 3 hygienists total, but Jafer, she is my main one. In Miami, it's interesting because most of the hygienists are foreign trained dentists. So she is actually from, I think, Cuba, and she had a dental license there, and she's trying to get her US dental license. And so part of that process is they have to work for a certain number of years in the US, either as a dental assistant or a hygienist, and then they can go and do an American dental residency, take all of the same board exams that we take, and then they can get their US license. So they're excellent team members to have because they can speak dental terminology in Spanish or other languages potentially to foreign speaking patients. And it helps to build a connection. Not all the patients coming in will immediately feel connected to me because I'm a white guy and I look young. But if they can talk to another person who's from Cuba, they immediately feel comfortable. So it's all about having a diverse team, and so that the patient can bond with at least one person in your office. And that way they come back, they trust you, they trust your team, they recognize familiar faces. And then the lower right picture is another picture of my dental team before coronavirus, where I had them all over to my apartment in Miami. So once per month, I have the entire team over and I make them lunch, just kind of a way to help the team bond and create a stronger team unit environment outside of the office setting. And then these are my 2 dogs. I have 2 French bulldogs. The black one's name is Bruce Wayne because he reminded us of Batman. And then the little white one, we named her Selena, which is Catwoman's name. So she is about 10 weeks now. Bruce is 1 year and 3 months. So it's fun to see them growing up. And So how did I get to all those pictures where I currently am right now? Exploring dentistry. So what is dentistry? Dentistry is a doctor of oral health. So we are physicians, we are doctors, even though you'll always have patients saying, oh, well, you're not a doctor, you're a dentist. I'm like, well, I am a doctor who decided to specialize in oral health. Our top 3 priorities are prevention and treatment of oral disease, restoring oral health. So the main components that we're focusing on are the teeth, the bones, including the jaw and lower face, the oral mucosa, your gum tissue, and also the systemic impact, because dentists see their patients more frequently than primary care physicians. So we have the opportunity, and hygienists have the opportunity, to catch systemic diseases much earlier than a PCP would, such as diabetes, any type of thyroid disorders, and some other ones that I'll go into later in the presentation. And the third priority is pretty much everything that we do in dentistry also has the added component of wanting to improve the overall appearance. So along with being providers of improving health, we also improve appearance, which makes dentistry very unique compared to other areas of medicine and healthcare. For the anatomic focus, again, we have the teeth, the bones, the temporomandibular joints, and all of the supporting muscles, the lymphatic system, nerves, arteries, and veins. And then the focus that I have in my office with my team is that I have 2 general dentists, myself and Dr. Sweeney, my associate. I have 3 specialists who work in the office. One is a periodontist, so a gum specialist, an endodontist, who's a root canal specialist, and an oral surgeon. I have 3 hygienists, 4 dental assistants, and 3 front office team members. So when I started my office, I didn't have that big of a team. It was just 1 general dentist, no specialty, no hygienists, 1.5 dental assistants, so the half would be part-time, and just 1 front office. And I opened the office back in July of 2019, and it's grown exponentially. Even we stayed open all through coronavirus. During coronavirus, we cut down even more to just 1 doctor being me, 1 dental assistant, and 1 front desk. So just a skeleton team of 3 people. And we were able to keep it going. And the ability of having the office open throughout the pandemic built a lot of rapport and credibility with patients who had emergencies, because pretty much all the other offices were closed. But we had the business support and financial resources available to remain functional almost 7 days a week. And so again, one of the big focuses more and more with dentistry is access to care. So patients work. The patients who are able to pay for treatments, they're working during the day. So they need to come either early morning or late at night, or they need to come on the weekends. So the days of dentistry just being 10 to 4 or whatever you want to think it is it's not a reality. If you want to be able to serve people and serve the ones that need your care, you need to figure out, are you going to have another associate that can help you offer expanded hours, or are you comfortable with working that many hours? So a lot of days, my office is open from 8 a.m. to 7 p.m. We're also open Saturdays. And again, the goal is to have increased access to care so we can really help and serve as much of the community as possible. My approach is all comprehensive. I'm not just specifically focused on cosmetics. I like to treat disease because that's where the main purpose of dentistry is. So with a comprehensive mindset, that means that we need to have access to all of the resources similar to like a hospital, which is why I have all the specialists come to the office. So I have my root canal specialist, my gum specialist, the oral surgeon, and all the hygienists. So that way I never have to send a patient away. Any problem that comes in, no matter how big or small, I can tell the patient, we can help you. And that's a very powerful thing to be able to do, because then the patient feels comfortable. They're always coming back to the same location. They know the front desk team, any type of financial arrangements they set up are for all the doctors, regardless if it's a specialist or a general dentist. Insurance verification is all the same. And then we're also able to offer a lot more technology. So you have cone beams, CT scans, digital dentistry, also use of a lot of laser, oral cancer screening, viewing systems. And I have, again, at the end, more of the technology components. So how did I get to the current practice where I am right now, I started out at Dickinson College in Carlisle, Pennsylvania, and I double majored in biochemistry and biology. I was one of those weird kids where my science GPA was higher than my regular GPA. So I hated foreign language and all those other things. The distribution requirements killed me because my mind was just, it's always been wired mainly for science. With the DAT, my composite score was a 23 and my perceptual ability was 22. A lot of the shadowing experiences that I had prior to dental school were hospital-based. I started volunteering in a hospital back when I was actually in middle school as a patient transport and just like greeter in the waiting room to help patients figure out where to go. And I did a lot of shadowing in academic dentistry and medicine and also in private practice settings. Some of the jobs that I had that were relevant, I did a lot of clinical research during the summers because I'm from Baltimore originally. I did 5 consecutive summers of research at Johns Hopkins in their Lou Gehrig's disease ALS department. And one of the benefits was that I was on 3 publications that were published, and I was second author on all those, which was a huge help in terms of showing that I could commit to things long term. I also worked in gyms part-time, mainly at 6 a.m. before I would have classes. Eventually, I was a paid patient transport in the hospital setting, and I also did a lot of tutoring for high school students. And while in college, the biggest things that you want to be focusing on is becoming a well-rounded applicant. Dentistry requires a lot from you as a doctor, and the admissions committees are looking for someone who isn't too slanted in one direction more than the other. So they're looking for someone who's well-rounded. What does that mean? It means that academically you're solid. You don't have to be top of the class, but you're strong. Your entrance exams, your DATs are above average. Again, they don't have to be top 2%. You have community service, shows that you want to give back because the main essence of being a doctor is that you want to do good to others and improve their quality of life. You've engaged in some leadership opportunities. Being a dentist more than any type of doctor requires you to be a leader and to be the quarterback for your team of everybody in your office and coordinate comprehensive care for patients, even if it's not being done by you, but it's being done by your specialist or your hygienist. Admissions committees also want to see that you know what you're getting into. So you need to have documentation that you've shadowed dentists or shadowed healthcare type settings. You've at least been exposed to the intensity, the flow, the rhythm, the pace, what it requires of the individual day to day. They also want to see that you've been engaged in some type of research. Maybe you get a publication out of it, maybe you didn't. If you did, it's just extra points for you. And also networking and building relationships while you're in undergrad is very important. Connecting with dentists in the community, connecting with dentists who went to the school that you want to go to is a huge thing that you can do, or students who are currently enrolled in their program, because you want to get those strong letters of recommendation. The admissions committees for dental schools really look at the entire applicant. I was on the admissions committee for University of Maryland for 2 years. Which is why I have a little more knowledge as to what they're looking for. And it's really about the person. As long as you meet the minimum standards for what they will accept at a specific school, if they bring you in for an interview, they're really trying to figure out, do they like your personality? Would I want to be around you for 4 years? So that's the main thing. If they don't like your personality, then you don't really have a chance. So it's really about being honest, being genuine, being authentic, knowing who you are. Don't try to be fake because they'll figure it out eventually. And just being honest about your intentions. 2 of the big questions that you need to ask yourself as you're getting towards the end of dental school is what type of work environment do you want to be in? What type of daily schedule do you want to have? Do you want to specialize, or do you want to be a general dentist? What type of pace do you want to have as you're working day to day in terms of the number of patients per day? Are you having hygienists or other specialists in your office? What type of procedures do you want to do? What type of patients do you want to be seeing in terms of heavily insurance-based or cash-paying patients? The more specific you get, the more limiting you are in terms of what type of patients will be drawn to your office. So, I mean, my advice, especially again, is we're in a very different landscape than we were a year ago, is to be as open to anything as possible. My goal was to create an office where I could build a reputation for providing comprehensive care and having the most advanced technology in the office, where patients can also receive specialty treatment in an environment where all of my doctors and my staff and team members can develop really strong relationships and trust with the patients so that they come back, they bring their family, they bring their children. Word of mouth spread is the best type of marketing that you can have. And no matter how much you pay for Instagram or Facebook, if someone says, oh yeah, I saw Dr. Tolmie the other week and he was great, that will immediately get you someone to come in and do treatment versus the $1,000 a month you're paying for Instagram posts. So word of mouth spread is the biggest and best way and the most long-term sustainable way you can continue to grow your practice as a dentist. I was also really trying to focus on getting clinical autonomy, again, advanced technology, having all the specialists available, and having the opportunity to also develop new doctors because I also like to teach. So let's see here. For a practice environment, the different types of settings that you can go into after dental school, you can go into military. The advantage of that is that they help pay off some of your student debt. I did not go that way, so I have a lot of student debt right now. There's also public health. That's also another way that they can help pay down some of your student loans. You can also go more of the academic route. If you like research, there's a lot of research in dentistry. Dentists are always looking to develop new technology. So there's also that side of the research component. You can go into a private practice setting, which again is heavily reliant on the dentist creating the business side of the office, also deciding if they want to go with insurance or fully cash paying or a hybrid of both. Or you can go into a dental service organization, a DSO. Some people call it corporate dentistry. Those are kind of the main buckets that you can explore as you get closer towards your graduation point within dental school. And some of the things that you need to access in terms of how you want to practice is, again, access to care, so the hours that your office is open. Because again, it's all about work-life integration. Not necessarily work-life balance, that doesn't really exist, but it's more how you can integrate your work life and your personal life together, because they need to coexist. Some weeks your work life is going to take a lot more of you than it does other weeks. So you need to learn how to integrate all of your personal commitments with your work commitments so that they can coexist with each other and they can be adaptable as the demands of one is changing more than the other. Also, the location of where you want to work geographically is a very important thing if you know specifically where you want to work. I had some friends who were like, I don't care where I'll work. When I graduate from dental school, I'm just going to go wherever the best opportunity is. The scope of treatment that you're offering, again, do you want to be able to tell any patient walking in the door that you can help them, or are you going to be sending patients out for referrals at different offices? The patient demographic, do you want to be in mainly a residential area or a region where there's some high-rise office buildings? Or do you want to be in a region where there's a lot of apartment buildings where there's constantly a new flow of patients every year, because apartment rentals on average are about 1 to 2 years. So you have a constant new flow of patients, but you don't have a lot of long-term care patients. And also business support. Do you want a company that's developed a system to help you with that? Or are you going to try to do it all on your own? And so in terms of being a general dentist or specializing, the different concentrations in terms of specialty are periodontics, which is a gum specialist, endodontics, a root canal specialist, oral surgery, also orthodontics, and pediatric dentistry and geriatric dentistry. In terms of number of years after school, the endodontist, periodontist, and orthodontist, I believe, they're usually either 2 or 3 years. The 3-year programs usually get a master's in science degree. The 2-year programs are a certificate. And then oral surgery is either 4 years or 8 years. The 4 years is a master's. And then the 8 years is if you want to do the dual degree, the DES MD route. Then you can also specialize in pediatric dentistry or geriatric dentistry. So those are usually, again, 2 to 3 year programs. So going into my current work environment, so I'm going to give you an idea as to kind of what my daily schedule is like, what type of patients I'm seeing, and the most frequent procedures that I'm personally doing. And we'll go into some examples of those also. So the daily schedule I have 2 offices. One is in Miami, Florida, specifically in an area called Midtown. And the other one, which I'm a partner in, is on the west coast of Florida. I have a dentist who's there mainly. So the support that I provide her is a lot of mentoring. I go out there occasionally and to help her with more complex cases, but I trust her. And the goal is to have her develop the office, and then I'm there to help guide her and develop her and figure out how she can build her clinical culture. But the office that I'm in most of the time is open 8 a.m. to 5 p.m., Monday through Thursday. On Wednesdays and Thursdays with my associate, she comes in at 10 a.m. and stays till 7 p.m. And then on Fridays and Saturdays, we limit the hours some and work from 9 to 3. But there is flexibility in that. Like if I have something I want to do on the weekend, or I want to go out of town, we'll close on the Saturday. It's all about the relationship you have with your office manager and your front desk team, and giving them warnings so that they can properly move patients around that might have been pre-scheduled. I work 5 to 6 days a week. I love my job and I enjoy working because it gives me a lot of fulfillment and satisfaction, and I can feel myself getting better every day. I know when I was in dental school, I mainly heard that dentists work like 5 to 4 days a week. And that may be true at some point in my career. Definitely not true right now because you have a ton of student debt to pay off. And also, this is in the beginning of your journey. You're not an expert and you don't know anything. Dental school just basically teaches you how not to kill someone. And you become a master at what you do by doing it over and over and over again and getting exposure to as many cases as you can. And the only way to get exposed to a ton of cases is to be available. And they'll tell you this in dental school. Even if you don't have a patient in dental school, you should be there assisting your classmates, learning what they're doing, seeing how they're managing patients, hearing what the professors are telling them. Those hours and opportunities to see things are invaluable. So another piece of advice is just to be as present as you can. The structure of my daily schedule, where I am currently, I didn't start out like this. It took me a while to ramp up to it, but I have 3 to 4 columns of patients. So on a daily basis, I could have anywhere from 3 to 5 new patient appointments, which are 2 hours each because we have to do insurance verification, all of their initial x-rays, initial patient interview, checking out their gum health, also doing a clinical exam, and then talking to the patient about the treatment options they have for any pre-existing diseases, and then coordination with the office manager and benefits coordinator to see whether insurance covers, because most patients have no idea how their insurance works. They think it covers everything. They think that they won't have to pay anything. So it's a lot of conversations that you need a good office manager who can talk about that type of stuff with the patient. So that would be the first column, is mainly new patients. The second column is pre-scheduled treatment. So patients that couldn't do same-day care, they might have had to go to work or was at the end of the day. Then they scheduled later out to say, okay, I'm going to come in a week to do the crown, or I need to come in and have a tooth extracted. So the middle column is all pre-scheduled treatment. Then the third column is continuing care patients. So patients that are coming for their 6-month check. It's also hygiene patients that are coming in for cleanings with my hygienist, and also post-operative patients. So ones that I need to check that I've done surgery on, or they're having crowns delivered, or they're getting dentures, or they're having some type of digital dentistry treatments. I have a pretty diverse population of patients that I deal with, which I like. Variety is a good thing because it makes you more adaptable in new situations. So most of my new patients and continuing care patients are ages 20 to 60. It's pretty much a middle class environment. The uniqueness is that with that type of patient population, they're working. So again, mornings and evenings and Saturday appointments are in high demand. In terms of where the patients are coming from, there are permanent residents from Miami. There's also a lot of high-rise residential buildings around where my office is. So there's a constant turnover of new patients, including patients who are university students at University of Miami. Because it's Miami, we do get a lot of emergencies who are out-of-town people on vacation and they fell on the boat and cracked their tooth and they need someone to fix it. Spring break right now, we always get people who did something the night before and they messed up their mouth and they're coming in. So we get some interesting stories. Because we're right by the port of Miami, we get a lot of cruise ship staff because they don't have dentists that travel on their cruise ships. So anytime that they dock in a port, a lot of them have to get dental care because they've been out to sea for multiple weeks at a time. We're also very close to the University of Miami Hospital. So I have a lot of medical residents, nursing students, and doctors and attendings and nurses and PAs, all that come and get care. And in terms of the needs, everything from infections to the typical restorative composites, fillings, to patients who want composite veneers. With the emergencies, we always try to focus on same-day treatment to get the patient out of pain. So that could be anything from doing a surgery to a root canal to remove the nerve of an infected tooth, to patients who have gum infection that's become symptomatic. And also with coronavirus, there's been a huge rise of cracked teeth. People are at home, they're stressed, they're clenching and grinding. They're also eating a lot more food that's not good for them because they're just sitting in their kitchen working all day. So the rise in cracked teeth, bruxism, clenching, grinding, jaw pain, recession, abrasion of teeth, all of that has increased tremendously over the past year. And then because I've developed the office to have all of my specialists in-house, I also get a lot of outside referrals from private practice offices that can't offer the specialty treatment. So they'll say, go to Dr. Tolmie's office to get your root canal or go to Dr. Tolmie's office to get your wisdom teeth out. So we can also provide that service to surrounding dental offices. The most frequent procedures that I personally do, in terms of the restorative side, you need to kind of categorize it into two buckets. So are you going to renovate something and try to keep it like a house, or are you going to try to replace it? So patients always tend to forget that you're using your teeth all throughout the day and all throughout the night. They think that they're never going to wear down. They think that as soon as you do treatment, they'll never have pain again and never need to fix it. But you need to give them analogies to understand. It's like your teeth are just like tires on your car. You're always using them. Tires need to be replaced or repaired. Your teeth need to be replaced or repaired. The enamel, even though it's harder than bone, it doesn't last forever. So in terms of renovating, when you want to try to save a tooth, it could be anything from a composite filling, sometimes the metal amalgam fillings. Inlays and onlays are porcelain fillings that are for medium-sized cavities. For really large cavities, we're talking anything from a crown to a veneer. And again, the smallest cavities are the composite fillings. When replacing teeth, meaning that the tooth is hopeless because the cavity's gotten too big, the ways that we replace them, you have three options. You have a denture, which comes in and out, a bridge, which is a permanent solution, it gets cemented in place, or an implant, which is a root replacement. I do a lot of surgical cases. University of Maryland Dental School, they have a really great oral surgery clerkship for fourth-year dental students that you can do. So in dental school, the first 2 years are heavily academic with some lab-based training, and then the third and fourth year are mainly clinical-based with less lecture. If you do really well in your third year in terms of getting your graduation requirements checked off, you have the opportunity to become an oral surgery clerk. What that means is that you get to work along with the oral surgery residents and work in the urgent care clinic at the dental school and do all surgical cases. It's really cool because I think by the time I graduated, I had extracted over like 150 teeth, where people who were graduating from other dental schools had extracted 5. So it was like a tremendous difference. I'd done impacted wisdom teeth, tori removal, full mouth extraction cases, worked on special needs patients, geriatric patients. So it's a really invaluable experience that can help you determine what you like and what you don't like before you even start working. So in terms of the surgical side, GP means general practice. So a general dentist can do surgeries. There's also specialists, SPC, who do oral surgery. So I do simple and surgical extractions based off of the complexity through radiographic exam. Socket preservation, meaning that after you remove a tooth, you have to preserve the hole that the tooth used to be in. Otherwise, the bone atrophies and collapses. So that means bone grafting and making sure that it heals properly, especially with patients that smoke or don't follow post-op directions. Bone augmentation. So that would be for a patient who's been missing their teeth for a while and now they want to get a denture, or now they want to get implants and their bone isn't the correct shape anatomically. So you need to go in surgically and reshape the bone. Also doing biopsies for suspicious lesions for oral cancer screening, and then sending them to a pathology lab to get a pathology report. For root canals, I personally don't do them because I do not enjoy root canals. I have nothing against them. I think they're a great treatment. But for me, the way my mind works and the way I know myself and what I enjoy personally, I don't enjoy them. So the nice thing about my practice, because I have a root canal specialist who comes there, I can add them all to her schedule. So I don't have to turn away any patient who needs a root canal. I still do the crown for the patient. I do the initial access for the root canal procedure. And then I put the patient on pain management medications and antibiotics until the root canal specialist comes that week. She comes about 4 to 6 times per month. For periodontal gum health, I do some of those. That's the GP. I also work with my hygienist who helps me manage those. And then we also have a specialist. So there's surgical and non-surgical gum treatment depending on the severity of the infection of the patient's gums. But the kind of the bread and butter treatment for gums to keep them healthy are doing what's called a deep cleaning or a scaling root planing. Also irrigation with an antibiotic. And then we use a lot of laser in dentistry in order to decontaminate the gums. Some of the other procedures, do Invisalign, Botox, fillers, whitening. So pretty much everything, which is why I wanted to go into general dentistry, because I like to be able to switch from day to day what I'm doing, and you never really know what's going to walk in the door. So you get to develop a lot of skills over time if you're open to trying new things and learning. And some example cases that I have. So these are some crown and bridge cases. On the far left, I was a patient who had a big infection in one of their front teeth, so I surgically removed it. Then we did bone grafting and prepared the adjacent teeth in order to hold the bridge. So he did not want an implant option. So an implant, biggest difference between implant and bridge is the amount of time you have to wait until you get to the final product. With a bridge, you can basically get there in about 2 to 3 weeks. With an implant, the patient has to realize it's going to be close to a year before you get to the end result. So this patient didn't want to wait. So we ended up going with the bridge. Personally, he was happy with it. I think it looks great. You also have to remember, as a dentist, you're looking at everything under super high magnification with an LED light. So when you're looking at it and you've been looking at it for hours, you obsess over all these little details, and in your head, you're like, oh, it looks like crap. And then all of a sudden you give the patient the mirror and they're like, I love it. I'm like, great. Okay. So remember, it's all about the patient. Let them say what they think first, because dentists, the great dentists, are the ones who are the obsessive, compulsive perfectionists, but that can also hinder us at different times. So you need to learn how to control it. It will never go away, but knowing how to control it is important. The middle case is a patient who had an accident on a golf course, so he lost his upper 4 teeth. He had been without them for a while. You can see the gum tissue had already healed. So he had been like this, I think, for about a year and a half. And so we did another bridge from his canine to canine, and he had an open bite already, didn't want to go into orthodontics to correct his bite. So this is what he was happy with. The patient on the far right, she bit down into a fork. I don't know what type of fork would do that type of damage, but that's what she said. And then she had to go to her daughter's wedding in 5 days, and the wedding was out of town, and she wouldn't be back from the wedding for 3 months. So again, remember I said 3 weeks to get the end of your bridge. So what we did, this is why it's important to have good relationships and have digital dentistry. So I was able to extract the main fractured tooth. That day, I also had the root canal specialist in my office, so she did a root canal on the other front tooth that's heavily fractured. I called my lab owner, who's in Northern Florida, told him I would be sending him a case digitally, and so we took a digital impression of the teeth. He started fabricating it that night and overnighted it with FedEx within a day to me, and this patient returned the day before she was flying out of town to get the bridge permanently cemented before her daughter's wedding. The day of the wedding, I got a really nice text from her saying how happy she was, how much confidence she had. So it's a collaboration of a lot of things that as a general dentist, you need to be able to organize all of those things mentally and align them and sequence them in order to get to the product that you want. And none of that happens on your own. You have to have those relationships where you can call on people to do you favors in order to help serve the patient. Some more crown and bridge, the far left. You get a lot of patients who break their teeth on beer bottles. They will never learn to not open them with that. So she had cracked her tooth. This is another case where technology in the office was heavily utilized because I made that crown in the office and cemented it. It took about 2 hours total from when she came in to prepare the tooth, take a digital impression. I designed it on the computer myself. Then we milled it out on our machine in the office, put it in a kiln, a sintering machine, glazed, polished, stained, and then cemented it. And in 2 hours, she was walking out the door. The middle case was a patient who was never happy with the positioning of his upper front teeth, didn't want to do braces. So I said, I think we can do some things digitally. And so without moving the teeth, I was able to redesign the crowns in the computer system to give the appearance that they were in better alignment. The far right case is another bridge example where the patient lost the tooth. What's important to see with this one is where the tooth is missing, you can see how nicely the gum tissue was contoured to make it look like once the bridge was cemented, that fake tooth was actually coming out of the gums. So having healthy gum tissue, molding it appropriately is important in terms of getting a believable long-term result. Some more crown and bridge, the far left was a patient who used to be a dental technician, and she wanted her new crown to match her stained teeth. So that takes porcelain ceramist, someone who's talented to know what they're doing. So sending a picture along with your digital impression to the lab allows them to do the correct staining and glazing in order to appropriately match it to the patient's existing dentition. This is one of the hardest things to do. When patients come in, they're like, I would just want to replace this one. And you're like, okay, well, for symmetry purposes and appearance, let's do both side by side. Like, no, I only want to do what my insurance will cover. All right. So insurance doesn't cover cosmetic. So that means you're stuck doing one crown. And you really have to make sure that you control patients' expectations very well, document it with pictures, and document that you had the conversation so that the patient knows this will never be an exact match. You'll do as good as you can, but it will never be an exact match. And some of them will get the crown, it's a little lighter, and then they'll say, you know what, I actually do want to do my neighboring teeth. And we'll do crowns or veneers on those in order to match the tooth that had pathology, that had an infection. The right case is a strict cosmetic case. So they had tetracycline staining, which you'll see. For me, it's mainly the population that's in their 60s. For you guys, if you go to dental school and then graduate, it would be the population probably when they're in their 70s. Because they used to give tetracycline to children when they were sick as an antibiotic. And then they later realized that drug, that antibiotic, binds calcium in teeth and permanently stains them to be this like smoker brown color. And the only way to correct it is to do veneers or crowns. So those patients typically have crowns or veneers from premolar to premolar, about 8 teeth on the top, 8 teeth on the bottom. Endodontics, again, root canals. So you can need to do a root canal sometimes for 2 reasons. One is because there's an infection inside the tooth that's gone down and created an abscess. The other reason is that there was an infection outside the tooth in the gums that went down to the root and created an abscess. So the far left is an example of patient who had really poor oral health and they needed to have a root canal due to an infection that went around the tooth down and created an abscess at the bottom on that center picture. And again, after any root canal, you always do a crown. The root canal removes the nerve and the blood supply to the tooth, so it becomes very brittle. Long term, it dries out. So putting a crown on it re-strengthens it, prevents it from fracturing in the future when the patient bites on granola or bites on a fork or falls on a boat. Bone grafting, here's an example. The two left teeth had infections. I removed them, did bone grafting. You can see after about 3 months it healed. Now that patient is a candidate to have implants. If they had not done bone grafting, they would have had a big defect in the bone and they would not be able to do implants long term. So having that conversation with patients about what their options will be after the healing period is important, because on the day of treatment, when you're removing the teeth, if they decide not to do bone grafting, then they can do bone grafting later on, but it's a lot more invasive. It's less predictable in terms of the outcomes. It's more expensive. So making sure that you're very clear with them up front is important. Here's the bone grafting procedure. I love doing these. This is also where we were doing an implant same day. So the upper left picture was after I had cut off the crown. So we had taken the tooth down to bone level, and then we're cutting the tooth in half. So doing an extraction as atraumatically as possible is important because you want to have as much of the surrounding bone as possible. So in order to do that, cut the tooth off at the crown level. Then we put the implant drill and drilled all of the pilot holes before removing the tooth. And then once we had placed the implant, then we took the tooth components out. And then on the lower left picture, that is after we had placed the bone graft material on top and around the implant, and then had placed the membrane in that center picture so that the gum tissue doesn't grow back in, because gum tissue grows like grass. It grows all the time. So you want to prevent it from going into the extraction site before it heals. Lower right picture is healing after about, I think that was 3 months. This is a patient giving an example of periodontal health. So the left side is why it's important to treat recession. So you can see there in the upper left picture, then going across those 3 to the third is when the gum tissue was removed. So you're explaining to patients, the reason you have recession is because you've lost bone on the front of your tooth. It could be because of orthodontic tooth movements. It could be because you're not doing a good job of keeping your teeth clean at home. You could be aggressively brushing. You could be clinching or grinding. All those things can cause recession. So when treating it, you do gum grafts with the specialist, and then that's what it can look like in the end. The right patient was when I did a full mouth extraction case on, so we removed all the teeth. The lower right picture is an immediate denture, meaning that it's a denture that you give them the same day as the surgery so that they can walk out with something, at least to be able to smile with. Now with coronavirus, they're wearing masks, so a lot of them don't really care as much as they did. They're like, oh, I'm wearing a mask anyway, so it's fine. Okay, whatever makes you happy. Periodontal disease, again, is a big thing in dentistry because if your gums are unhealthy, it doesn't matter how beautiful any of your other work is, it will all fail because your gums are infected. So it's important, the statistics, the CDC, over 50% of Americans older than 30 have periodontal disease, which means gum infection that's led to bone loss. Americans over age 65, it's 70%. There's a strong Perio-Systemic Connection with heart disease, diabetes, rheumatoid arthritis, inflammatory diseases of the gastrointestinal system, all very well documented. And there's becoming more and more attention from primary care physicians that oral health is very important. The right diagram is just how we diagnose and grade periodontal disease based off of how much bone is around the tooth. So periodontal disease happens when gingivitis is left too long. So you have healthy tooth, then you have gingivitis, which is just inflamed gums. Gingivitis that sits there for too long causes bone to start to disintegrate, which then makes it periodontal disease. Unless there's bone involvement, it's gingivitis. Once the bone becomes involved, and it becomes periodontal disease. So again, the full body connection, there's a neurologic component. There's multiple publications that are coming out showing the direct connection between your gum health and the development of Alzheimer's later on in life. Cardiovascular disease in terms of atherosclerosis and coronary artery disease. oral health and having celiac disease, IBS, Crohn's disease, oral health and recurring respiratory infections, adverse pregnancy outcomes. When women are pregnant, their tooth health and gum health is very important because a lot of the oral bacteria that they have, they'll pass on to their developed baby. And a very strong connection between periodontal health and the patient's ability to control their diabetes. Because again, patients don't realize, or they don't think about it. The infected blood that's in your mouth goes everywhere in your body. And the most direct access, so the quickest things that an infection from your mouth can get to are your brain and your heart. So when you put it that way, the patient's like, whoa, oh yeah, okay. I guess it's important because those are the closest things versus you have an infection in your finger. It takes a long time for it to get to the brain versus if it's in your tooth, that's less than a half of a foot to get to your brain. So all putting things in perspective so patients can have more ownership of their health overall. Periodontal diagnosis, it's a big focus in dentistry again, because it's the foundation of all the work that you do. It's like the foundation of your house. If that's weak, then everything in the house is always going to have problems. So it's based off of looking at x-rays for bone loss, the patient's health history and dental history, if they have any systemic conditions like diabetes or predisposing conditions, their lifestyle, do they smoke, are they a chronic drinker, do they have a drug use problem, any genetics, does anybody in their family have gum disease? And then the clinical exam, we look to see how much bone there is, how much bleeding is present, if there's any recession or missing teeth. So on the left side, you probably had this at the dentist, they're doing that little thing where they poke around your teeth. So it's a little ruler that measures in millimeters. Healthy amount of pocket that's there is pretty much 1 to 4 millimeters. That's on the left side. On the right side, so that's where gingivitis has been there for too long and it's caused the bone to start to disintegrate. That's when the pockets get deeper. There's been inflammation left untreated for too long, and all of those inflammatory factors cause degradation of the bone. And so that bone loss causes a deeper pocket to develop. So that 3 now becomes a 5. I have some patients who come in with 12s and you can literally wiggle their teeth with your fingers. And there is a line that will be crossed where all the teeth become hopeless. So the goal is to try to catch it before then and have a combination between the general dentist, the hygienist, and the specialist, the periodontist, in order to save as many teeth as possible. So again, for periodontal treatment, non-surgical, there's the deep cleanings that patients call them, use of the antibiotic irrigation, use of the laser to decontaminate the gums, and local antibiotics as opposed to taking a pill. And there's also surgical treatment for pockets that are too deep to be reached with the hygienist instruments. So that'd be done by a specialist. So pocket reduction surgery, where they actually reflect the gum tissue and remove everything out through direct access. Tissue grafting for recession, bone grafting for patients that have had really extensive periodontal disease, and crown lengthening if they've also had recession around teeth needing crowns long-term. And more examples of periodontal treatment. Again, periodontal treatment that's left untreated for too long causes widespread problems. So these are patients who had untreated periodontal disease that led to rampant decay, meaning all their teeth had cavities. One of my first jobs out of dental school was at a drug and alcohol rehab clinic in northern Florida. And so I've seen a lot of these patients every day who were in rehab for previous substance abuse. And so both of these patients on the right and the left were less than 30 years old, and they needed all their teeth out. And they were getting dentures or implants, depending on the financial status of their family supporting them. But the problem with drug use is that they become neglectful of their oral care. They tend to crave high acid, high sugar foods, and they end up having dry mouth. So the trifecta of things that cause cavities are a dry mouth, high acid conditions, and then also sugar food for the bacteria to eat off of. It's not necessarily the amount of sugar, but it's the duration of exposure. So if a patient has 1 bag of M&Ms, but they're eating it all throughout the day, that's much worse than having 10 bags of M&Ms in 30 minutes. So again, it's the amount of time that that unfavorable environment is present in the mouth for cavities develop. Full mouth rehab cases for patients who have rampant decay and we can save most of their teeth, you end up doing a combination of crowns, bridges, implants, all things that are permanent, not coming in and out. So on the left side is before treatment was done. You can see it's a hodgepodge of different things. And on the right side was once we had cleaned everything up, crowns on all the individual teeth, and the patient's smile was dramatically improved. This is another full mouth rehab patient. So this is before we did anything. You can see the patient had a lot of bone loss, missing a lot of teeth. They had worn them down a lot. We end up doing what's called an all-on-4 case. So removal of all the teeth with immediate placement of implants in that left picture. And then long-term, a bridge was put on the implant. So it's not a denture, it's a bridge that is the whole upper arch and another bridge that's the whole lower arch. So the top right picture is the temporary bridge that they had as the gums were healing. The bottom right picture is the final bridge after everything had healed about 4 months following the initial surgery. We're over time. I'll finish up in like 3 minutes. And this was just a case study that I had from a patient who had severe grinding of his teeth. So you can see he was only 25 years old. Teeth are really short. So if we would have just put crowns on all those teeth without figuring out why, that would have been a problem. So it ended up being, I'm summarizing everything, that he was grinding his teeth at night because he was having acid reflux while sleeping and he wasn't aware of it. So while sleeping on his back, acid from his stomach was coming up through his throat. So the body's natural response to that is to try to swallow it back down. But in order to swallow, your body has to do a forward thrust of the mandible. So that opens up the back of the throat so that your body can swallow the gastric acid back down. So if you're constantly moving your lower jaw forward and back all throughout the night, it's going to wear down his teeth prematurely very quickly. So you can see his teeth are pretty much a monoplane. They're all flat. And he didn't know why. So I was talking with some of my colleagues who specialize in sleep dentistry, and I ended up sending him for a sleep study. And with the sleep study results, it showed that he was having nocturnal episodes of GERD, Gastroesophagel Reflux disease. He was having the number of arousal moments, meaning waking up from sleep, that were diagnostic of having a sleep disorder. So the bruxism triad is having grinding of your teeth at night, you're having sleep disturbances, the arousal moments where you wake up from your sleep, and sleep-related acid reflux. So those three things combined create tooth wear and jaw pain. And every morning he was waking up with jaw pain because he didn't realize he was grinding his teeth at night. So in order to treat that, before putting on all the crowns, we put him on a proton pump inhibitor, made sure that his sleep was improving, his moments of acid reflux were also decreasing, and then we also did the restorative treatment. So we had to lengthen the teeth because so much of them were ground down. We had to expose some of the tooth structure that was underneath the bone. And I'm getting ready to deliver his crowns in 2 weeks. So that's why I don't have a final picture yet. And then the last 2 minutes, technology that I use in my office, intraoral cameras. Again, these are incredibly important for showing the patients what the current condition is of their mouth. You would think that they look in the mirror, but they don't look. They don't ever look. They think they know what it looks like, but they don't. So being able to take pictures and show them to patients as you're doing that initial exam is incredibly powerful. It's also good for you as a clinician because you can show the patient, hey, your tooth actually was broken before you saw me and I didn't crack it when treating the tooth beside it. So having that documentation is important for you in terms of protecting your license, but also educating the patient. Digital dentistry using the CAD/CAM technology. I love this. I use it all the time. I do anywhere between 70 to 100 crowns a month because I can make them in the office and I've trained my team. We have a really good workflow. We can do a crown if we're on it in like 90 minutes. And I designed them myself. I put a lot of time into learning how to do it. And we have the milling unit and also the kiln, the sintering machine that fires the porcelain. And it's a great service because you can really have less chair time. The patient has to come back less, especially for those wanting same day treatment. You have more precise and accurate fits of the crown because it's all digital. You're not relying on impression material that can become distorted in the shipping process. And also, if anything needs to be redone, you can redo it right there, as opposed to having to bring the patient back in, use more impression material, which is very expensive, use more chair time. There's a lot of benefits. but your whole team has to be aligned in order for it to be successful. More pictures, more of the computer design component of it. And then 3D x-rays, CBCTs, these are very important in terms of planning implant surgeries, also trying to figure out where a non-responsive infection may be if the patient's had a root canal and the tooth is still symptomatic. Could be because the tooth is cracked, which you wouldn't see on a two-dimensional traditional x-ray. You have to have a 3D x-ray to see the crack in the root. Velscope for oral cancer screening. So this is a way to use a specific type of light to excite the mitotic figures within the mitochondria of cancerous cells, and they fluoresce in a different manner than the normal epithelial tissue surrounding that suspicious lesion. So again, this doesn't confirm anything. It just tells you, hey, you might want to look at this, you might want to take a biopsy, get more of an expert insight to see if there is something going on in a high-risk patient, meaning that they smoke or they're have alcohol use or a family history. Some examples again, you can see the difference in the lesion's appearance under normal light and under the Velscope light. You can also use this for documentation reasons and patient education. Use of the laser for gum treatment, also for patients that have too much gum tissue, so that's called crown lengthening. So on the far left is a patient who had really uneven gum length after they had orthodontic treatment for 2 years. So then I used the laser to recontour the gums. The bottom middle picture is right after the procedure was done. The nice thing about the laser also is that it cauterizes as you're doing the procedure. So there isn't a lot of bleeding. You don't have to use a lot of anesthetic because it's not as painful as using a scalpel, and it heals much faster. The lower right picture is less than 2 weeks to get to that type of result. And that's it. Sorry. Just about 5 minutes over.
Oh, no, you're completely fine on the time. Thank you, Dr. Tolmie, for this amazing presentation and taking the time to be here with us. With that said, we have a few questions in the chat, if that's all right with you.
Yeah, definitely.
Okay, sounds good. The first question is, how did you go about finding your mentor, like after dental school?
After dental school? It took a while.
Yeah.
So the first job I had was in the drug and alcohol rehab clinics, and the person that I worked for was never present. So I really didn't have a mentor, and that was one of the reasons that I left that job after a year. My second job was in a heavily Medicare, Medicaid practice where the practice owner was just focused on having as many general dentists work for him as possible so that he could make money. And again, he wasn't present. That's why I left that job. My third job was in a small private practice boutique that the patients only wanted to see her because she was so talented and nobody wanted to see me. I learned a lot from her and I still keep in touch with her, but in terms of getting experiences, I didn't get much in her office. The person who hired me for Pacific Dental, who is my current mentor and I learned the most from and who has personally invested the most time in my development. How did I meet him? I met him through one of his other dentists that he was mentoring. I shadowed her in her office a couple days, and then she connected me with him, and I had an interview with him and did some role playing, like case study reviews. He wanted to see how I treatment planned, and he wanted to see how well I took feedback and how coachable I was. And then he hired me from there. And so the biggest thing I'd say is not settling for less than ideal conditions that won't allow you to develop. So if you feel like you're not getting the development that you need, cut the ties, move on. It's not worth staying in a situation where you're feeling unappreciated and you're not feeling like you're getting the development that you need. You put in way too much time to get your degree to feel like you're just being a workhorse for someone. If that's what you want to do, that's fine. But if you want development, make sure that you're in a setting and an environment where developing other doctors is a priority. So that's my answer.
Our next question is, how do you deal with stress at the workplace? And what does it take for you and your team or fellow associates to work together successfully?
So the way I deal with stress in the work environment, so stress can come from a couple different areas. One is stress from upset patients who think something was intentionally done wrong, and then having to re-explain to them as to why we're doing certain steps, and that sometimes, depending on what's being done, things need to be broken down before they can be built back up again. So dealing with that type of stress is, for me, a lot of it is just like learning how to breathe. And I've done yoga for years. So taking a big calming exhale before I go in, and I know a patient is already tense and upset and they're angry, realizing that it's just usually because the patient doesn't understand. I know I uphold my integrity as the most important thing. And I know I have intentionally done something wrong or done something deceitful to a patient. So if they're upset, it's most likely because they didn't fully understand what's being done, and I just need to go back in and re-explain it to them. So getting mental calmness before you go into those stressful situations is important. Don't just jump into it, because as soon as you get emotional, you're not going to be thinking logically. And if you have two emotional people, meaning you and the patient, that's just a horrible situation. One of you has to be logical. So staying mentally calm, figuring out what it is for you. I also work out every day. Like, going to the gym is my thing. It's my time to let all my thoughts marinate, and I get any of my tension out. So having those leisure activities that you do outside of work is also important. It's not all about work. It's much more important to have good quality and not quantity. So focusing on really quality hours, doing what you need to do outside of work so that you can be your 100% self professionally is important.
Great. Thanks, doctor, for that answer. Thank you also for your presentation. Another question we had in the chat was, how did you decide on what dental school was for you, and what made you decide on the University of Maryland?
I didn't get into all of this because we were short on time, but I actually went to medical school before I went to dental school. So after graduating from Dickinson, I went to Philadelphia College of Osteopathic Medicine, thinking that I wanted to go into medicine. And it was about towards the end of my second year that I realized that it was a horrible thing to have to realize, because I had spent so many years, like since middle school, trying to get into medical school, and then to realize, like, crap, this is not what I wanted. That's a huge shot to your ego. And to accept it and then admit it and take ownership of it, that took a while. So I finished the program and then took 2 years off. I was a high school AP science teacher and rugby coach at night, and re-explored what I wanted to do with my life. Shadowed a bunch of dentists, shadowed a bunch of doctors again, compared their lifestyles and what their focus was. The main thing that I wanted to do was to be able to have hands-on care with my patients. I wanted to be able to be directly responsible for improving their quality of life and doing something with my hands, not just writing a bunch of prescriptions, ordering a bunch of labs, ordering a bunch of x-rays. So in terms of medicine versus dentistry, that was the biggest thing that helped me realize where I had fallen off track in terms of figuring out what I wanted, and I should have continued along the dental track and not gone to medical school, where those years in medical school were very valuable, like in terms of patient communication, systemic understanding of disease. But I hadn't really realized how much I like to work with my hands, and that's where kind of the mismatch was. So when I was applying to dental school, I wanted to go to what I thought was the best dental school in the world, which is University of Maryland, because it was the first dental school in the world. So in my mind, if they've been in existence that long, they must be doing something right. So that's why I wanted to go there. I applied to 2 dental schools. If I didn't get into Maryland, I was going to apply again the following year. So I applied to 2. And I built relationships with the admissions committee. I found a dentist in the Baltimore community who was on the admissions committee, connected with him, then used him to connect with the dean of admissions, met with her. And so that kind of helped me figure out which dental program was going to be most appropriate for me.
Thank you, Dr. Tolmie. So unfortunately, that's all the time that we have today for questions. We really appreciate you being here and for taking the time to answer all of our questions.
Sure.
Just before we end today's session. The link for the post quiz will be posted in our group meet. And yeah, just thank you again, Dr. Tolmie.